Just a few days before Dr. Anthony Fauci announced his retirement from the National Institute of Allergy and Infectious Diseases, he granted USA Today Studios a broad, free-ranging interview about the future of the world's health.
The danger of something like this recurring is real and present. We need to understand that. So in addition to getting a vaccine that would cover all variants, we also want to get a better vaccine that would protect better against infection and transmission.
We talked about how America can avoid another years-long shutdown for health crises.
The one thing I do hope is that our corporate memory persists. And as we get through COVID and we put it in the background, in the rearview mirror, as we say, we don't forget that we must maintain a level of pandemic preparedness that we don't let slip.
He addresses emerging or re-emerging viruses like monkeypox and polio. Dr. Fauci also addresses whether life in a pandemic world is the new norm.
Could we actually eradicate SARS-CoV-2, the cause of COVID? And I can tell you categorically the answer to that is going to be no.
I'd like to begin by talking a little bit about our everyday level of risk and what we might just have to kind of accept now in our regular lives. You know, the world is trying to maintain a semblance of normalcy now, but we're still existing with a pandemic in the background. You know, we also have monkeypox, a resurgence of polio in certain parts of the world. So how much is all of that now just expected to be our new normal?
Well, I think that when you talk about new normal, you have to focus predominantly on COVID. I mean, we have the emergence of infectious diseases more often than people realize. Many of them are relatively insignificant at a global level. Namely, they may have some impact on a relatively local level. For example, a few years ago with the Ebola outbreaks in West and Central Africa, with the Zika outbreak that we saw in Brazil, and then it sort of spilled over into the Caribbean with some cases in the United States. But COVID is really, truly unique. It is a pandemic of historic proportions, the likes of which we have not seen in well over 100 years, dating back to the iconic pandemic influenza of 1918, which killed anywhere from 50 to 100 million people globally in a population that was only 1/3 the size of what the population is today. So when you say get back to normal, you've got to put it into the context that we are still in a pandemic now, that it is in its third year. When we get to January of 2023, that will be the third year anniversary of a historic pandemic in which we've had, surprisingly, but unfortunately, tragically, multiple variants and surges. So rather than one big burst of an outbreak like you might have in a flu season, we've had outbreaks and lulls and then variants and then more outbreaks, to the point where it really has had an impact on the world that really is historic. So what does normal mean? How do we get back to normal? I tend to think about it, when you think about emerging infections, as what are the elements that you might hope for? Could we actually eradicate SARS-CoV-2, the cause of COVID? And I can tell you categorically the answer to that is going to be no, because we have only eradicated from the face of the earth one significant pathogen, and that's smallpox. But we did that because smallpox, when you get infected or vaccinated with it, you get immunity that lasts at least decades and maybe lifelong. And smallpox doesn't vary very much. The smallpox that was available and infecting people hundreds of years ago is the same smallpox that we eradicated in 1977, 1980. So the next question is, can we at least eliminate it from the United States? And the answer is, I don't think we can, because when you eliminate it means you get enough protection in the community that it disappears, at least in a specific geographic location. For example, we've eliminated measles and polio from the United States, again, with a good reason, because those particular viruses, the protection you get from either prior infection or vaccination lasts literally decades and likely almost a lifetime, and neither measles nor polio changes very much. Then you get to COVID, and we have a real problem because we know now from experience with the common cold coronavirus, and SARS-CoV-2 is a coronavirus, and we're learning painfully from our experience over the last 2.5 years with COVID that it continually changes and you get new variants. And for reasons we still don't fully appreciate, the immunity that you get from prior infection, as well as from vaccination, lasts literally for months to a year and not lifetime like we see with smallpox. So we're going to have to get this virus to a low enough level that it doesn't disrupt the social order. Right now, we're not there yet. We're still getting, 100,000 infections a day, and we still have about 400 deaths a day. So we're not at a point of equilibrium that I think is appropriate that we can say, okay, it's all right to live with it. We've got to get the level of infection much lower. And that will happen if we can get more and more people vaccinated, or we could do it the hard way and get enough people infected that there's enough baseline immunity throughout the country or throughout the world, for that matter, so that you're not going to eliminate it or eradicate it, but it is going to be at such a low smoldering level that we'll go about our lives and it won't disrupt us the way it's disrupting us now. That is what the new normal is going to be. It's not going to be an absence of COVID. It's going to be a living with it at a low enough level that it doesn't disrupt us.
Right. So, you mentioned vaccines as, one of the major solutions in all of this, but globalization being what it is, people are resuming travel again. What kind of precautions do we need to be taking that maybe we're not taking right now, or that have been eliminated that we should still be considering?
Well, I think one that's very clear is that we know now, despite the argument against, that well-fitted, proper masks go a long way to prevent both the acquisition and transmission of SARS-CoV-2. That is just a fact. So one of the things that we may not be doing as well as we should is that when you are in a zone, an area, a state, a county, a city, a country, where the dynamics of the infection are very high, namely in the United States, the CDC codes a region or a city or a state as red or orange or yellow or green. If you're at a high level, it is very prudent to wear a mask in a congregate indoor setting. That's one of the things that I don't think we do as well, because we want so badly to put COVID behind us that you don't need to wear a mask all the time. You certainly don't need to wear a mask outdoors. But when you're in an indoor congregate setting, I think people are too readily taking their masks off. The next thing is that we are doing very poorly as a nation in getting people vaccinated and boosted. For a wealthy country like the United States that has all of the resources necessary to get everybody vaccinated and boosted up to date, we rank relatively low in the world, even when you compare us with developing low and middle income countries. We only have 67% of the total population vaccinated with 2 doses of an mRNA, and only half of those have received their first boost. And we're doing very poorly on the percentage of younger kids, children, who are getting vaccinated. So there are very number of important things, including vaccination, as I just mentioned, that we can do better if we want to make sure we can control this and protect ourselves better than we're doing right now.
The CDC is attempting a reset after identifying missteps in the early stages of the pandemic. What else do you think can be done in your experience to make sure that we don't go through the same thing again if we're faced with another potential pandemic?
Well, we must be prepared for a pandemic, and I do hope and I believe there will be very painful lessons that we've learned from the experience that we've had over the last 2.5 years. I don't really foresee shutting down anything, including in the context of the current COVID-19 pandemic that still lingers. The idea of another pandemic as serious as this is certainly possible. But, given historically that the last one we saw of this magnitude of severity was over 100 years ago, the one thing I do hope is that our corporate memory persists. And as we get through COVID and we put it in the background, in the rearview mirror, as we say, we don't forget that we must maintain a level of pandemic preparedness that we don't let slip. And not only pandemic preparedness, but an organized, well-orchestrated response if and when we do get, and I hope it's if and not when, we get the emergence of a pathogen that's as serious as SARS-CoV-2 was, and that is as serious as perhaps the 1918 pandemic influenza was.
You mentioned the limited longevity of the COVID vaccines, and it seems like the race is on to find a universal coronavirus vaccine, one that would protect against all variants. How important is that, and how feasible do you think it is right now?
Well, with regard to importance, it is the highest priority in the scientific community, particularly the institute I direct, which is fundamentally the major organization, funding and research organization responsible for funding our scientists throughout the country and even throughout the world to develop what we call a pan-coronavirus vaccine, not only one that covers all of the potential variants that might emerge, not only among SARS-CoV-2, but other coronaviruses, because remember, this emerged from an animal reservoir, and that animal reservoir is still out there. So the danger of something like this recurring is real and present. We need to understand that. So in addition to getting a vaccine that would cover all variants, we also want to get a better vaccine that would protect better against infection and transmission. And the way that is most likely the pathway to that would be getting a vaccine that's mucosally administered, namely one that would provide protection through the upper airway so that the virus you don't allow the virus to actually seed in your body. The vaccines that we give now by the usual subcutaneous route or intramuscular route generally protects very well against severity of disease, for example, lung involvement and other organ system involvement. But those vaccines don't protect as well against initial infection. And if you really want to protect the community, you want a vaccine that not only is broad in its breadth, namely a universal vaccine that gets all the variants, you want one that's durable, in which the protection doesn't wane significantly over several months. We want to make sure it lasts literally for years and years, but we also want to get a platform of a vaccine that protects much better against initial infection, and by therefore if it protects against initial infection, almost by definition, it would protect against transmission.
I know you're saying that COVID is really our primary focus, but I'm just curious why we are seeing the reemergence of diseases that we thought had been eradicated in certain parts of the world, like polio. Can you explain a little bit about that?
Well, we're dealing with two challenges now, and there's a reason for each of those. So let me see if I can briefly explain it as succinctly as possible. Let's take monkeypox. Monkeypox is very closely related to smallpox. And back when, decades ago, when the entire world, including myself, were vaccinated against smallpox, when smallpox was a global threat, there was no monkeypox in humans. It likely was below the radar screen in some animal species. But because people were protected against smallpox because of smallpox vaccination that was universal, we just didn't see human monkeypox. However, because we eradicated smallpox and the vaccinations globally stopped somewhere in the end of the 70s, 1980, 1977, then anybody born after that time is not protected against smallpox. And as a matter of fact, by definition, is not protected against monkeypox. So over the years, as monkeypox, which is endemic in southern Africa, in the central and western part of sub-Saharan Africa, it jumped from a species, from an animal to a human, but didn't have sustained transmission from person to person, until what happened is that the virus inserted itself into a population that was particularly vulnerable to human spread. And that is the population of men who have sex with men. So for one reason or other, the virus worked its way into the sexual networks of men who have sex with men. And that's why we're seeing in a non-endemic countries, namely over 90 countries throughout the world, including the United States, which is the most severely hit with over 12,000 cases, monkeypox is here in the human population. And we're not seeing spread from animals to humans because we don't really have animals here that are infected yet. We're seeing human to human spread. And again, well more than 95% among men who have sex with men. So that's an unfortunate quirk of the discontinuation of smallpox vaccination, the emergence into the human population of monkeypox, and now sustaining that in the human population because of the sexual networks that we see predominantly, but not exclusively, in men who have sex with men. That's the monkeypox explanation. The polio explanation is a little bit different. Polio, it can be given in two forms. In oral polio, which is a live attenuated vaccine that you give it orally, you swallow it, but it's live and attenuated. And one of the types, type 2 polio, can get excreted in the feces. And that's how polio is spread, by fecal oral contact. So what likely happened is that in certain countries that still use oral polio, we don't use that anymore in this country. We use the Salk version, not the Sabin version. The Salk is the killed polio. So it's impossible to get polio from the vaccine when you use the injectable Salk version. But in some countries, for good public health reasons, because you want to get a broader coverage, you use the oral polio vaccine. And sometimes it can then get into the stool, get into the sewage, get into a contaminated situation where someone actually gets infected from a polio that's derived from the vaccine. And that's what we saw in Rockland County in New York. That's exactly what happened. The way you counter that is to make sure that all of us here are up to date on our polio vaccines, namely the killed polio vaccine or the Salk version. In the community in Rockland County, it is striking how low the level of vaccination is against polio, as low as 60%. And in some counties there, it's as low as 37, 38%. So that's a problem for which there is a solution. And the solution is to make sure everyone is vaccinated against polio.
Thank you for explaining the differences, because I think with all these public health crises popping up, I think sometimes people don't really grasp what's involved in each one and how each one can be different. In one of your recent papers, you and your co-authors had written something that was striking. I mean, you said, "We remain at risk for the unforeseeable future." So at the rate that we're going, how often can we expect to see pandemics or larger public health crises happening?
The fact is it's unpredictable, and that is just the truth. How often are we going to see emerging infections? I think the answer to that is often. I have a slide that I've been showing for the last 40 years in which I put on the map of the world the emergence of a new microbe. That was HIV in 1981, first recognized. That probably happened before then. Then that's different types of influenza, bird flu. Then there's the emergence of Ebola. There's the emergence of Zika. And then we have the catastrophe of COVID-19. These emergences happen frequently. Only every once in a while do you actually get a pandemic where something emerges, usually from an animal host. It is noteworthy that about 75% of all the new emerging infections are what we call zoonotic. They emerge from an animal reservoir. Flu does that. HIV does that. Ebola does that. COVID does that. And when that happens, sometimes it's a curiosity and it doesn't spread widely. But every once in a while, it's a pandemic. And that's when you get global spread. And that's what we're seeing now with COVID. And that's what we've seen with several over the decades of pandemic influenza.
Dr. Fauci, thank you so much for your insight. We've been speaking with Dr. Anthony Fauci, immunologist and chief medical advisor to the president. Thank you so much for being with us.
Hey, thanks for watching. If you like this video, check out these other videos from USA Today to stay up to date with all the latest news.